A very good afternoon to all the attendees and welcome to the next session of the ISCP Congress. I hope you have enjoyed the last session on stroke prevention in atrial fibrillation. My name is Grace Chang and I'm a clinical pharmacist from Singapore. We take the discussion on atrial fibrillation a step further, focusing on prevention, on rhythm control, and holistic management via the ABC pathway. As such, this session is entitled When Your Atria Persist in Fibrillation. We are honored today to have 4 eminent faculty in the session. May I first introduce Professor Antoni Martínez-Rubio, who will be moderating this session with me. Our 3 speakers, whom I will go ahead to introduce, will follow. Before we start, the usual disclosures are that this webinar is under copyright and should not be distributed. Views and opinions expressed are that of faculty members and do not necessarily represent those of the ISCP. This session will be live streamed. CME points will be granted by the European Board of Accreditation at the end of the lecture. You will receive your certificate of attendance after the session concludes. Please use the live Q&A box if you have questions. We will try to answer as many questions as possible within the time limit. If it does not permit, you are most welcome to email questions to the Secretariat using the email address at the bottom of the screen. Without further ado, I would like to introduce Professor Jordi Dan. He is the head and senior consultant of the Internal Medicine Clinic and Cardiology Department at Colentina University, Bucharest, Romania. His talk is entitled, Do You Raise Upstream? All about upstream therapy. Professor Dan, please.
Hi, I'm Dr. Jordi Dan from Bucharest, Romania, and I have to talk all about upstream therapy in atrial fibrillation. The time is unfortunately too short, therefore I will talk only few about upstream therapy. I have nothing to declare regarding this presentation. In the general sense, the upstream therapy is any therapy aimed to prevent atrial fibrillation or its perpetuation. This therapy should act on the substrate remodeling, electrical remodeling, or on the functional remodeling. This kind of therapy includes drugs of interventions without generic antiarrhythmic properties. Cardiac substrate is the target for many known risk factors and diseases. Substrate remodeling makes micro-reentrant atrial fibrillation mechanism possible. However, atrial fibrillation itself modifies the substrate in the so-called common pathway. Therefore, atrial fibrillation is both a marker and a risk factor for substrate remodeling. Finally, the substrate is remodeled by aging, by disease, or by atrial fibrillation itself under the modulatory intervention of genetic factors or focal pulmonary sources. In this way, atrial fibrillation is in the center of several diseases like hypertension, heart failure, diabetes, or ischemic heart disease. In center of several generic processes like inflammation, oxidative stress, or renin-angiotensin and sympathetic activation, and under direct influence of fibrosis, autonomic tone, or electrical remodeling. All of these representing practically targets for upstream therapy. Obviously, the best place for the upstream therapy is placed at the very beginning of the substrate modeling. The efficacy is lower as the substrate is more and more remodeled. All this way, there is an increasing thromboembolic risk. As you can see from several randomized controlled trials and several retrospective trials, Some agents like renin-angiotensin inhibitors or mineral receptor antagonists or statins or omega-3 polyunsaturated fatty acids could have benefic effects in primary prevention, especially after surgery or in patients with significant underlying heart disease. You can see here statins, several studies with statins and with fish oil consumption. Despite promising results in secondary prevention in some small studies, large studies failed to show any real benefit for renin-angiotensin system inhibitors. The same was shown for statins. Several small studies demonstrated real benefit, but large studies failed to demonstrate any benefit. And this explains why the upstream therapy is now the class 2 indication in guidelines. Which are the reason for this failure in large studies? There could be many. Some are cited here. In many patients in the large studies, the substrate was already modified. So if the effect of the therapy is diminished. The second is a conceptual one, because the concept of one drug, one target is inoperative in complex situations like atrial fibrillation. And finally, many of these studies had a defective or oversimplified design. In the new paradigm, atrial fibrillation is only a non-mandatory partner of a complex atrial dysfunction called atrial cardiomyopathy, under the influence of many risk factors and cardiovascular dysfunctions. In this way, the traditional syntax atrial fibrillation begets atrial fibrillation become atrial cardiomyopathy begets atrial fibrillation, and atrial fibrillation begets atrial cardiomyopathy. This atrial cardiomyopathy is characterized by electrical functional remodeling and also by a different degree of fibrosis and procoagulant state, irrespective of the presence of atrial fibrillation. Obviously, the renin-angiotensin system has a crucial role in genesis and perpetuation of atrial fibrillation, intervening in the electrical and functional remodeling. You can see here the influence of angiotensin II on the action potential, duration, and on conduction abnormalities or structural remodeling. Also, was demonstrated that the absence of natriuretic peptide receptor C, which is a clearance receptor, had profibrillatory and profibrotic effect. On the contrary, the activation of such kind of receptors has antifibrillatory and antifibrotic effect. Equally, aldosterone play an important role in atrial fibrillation, not only because of the profibrotic effect, but also because of the intervention in the calcium metabolism in the myocyte. And also what is interesting, that is an increase in mineral receptors and aldosterone availability in atrial fibrillation, especially because increased metabolism of cortisol by the action of this enzyme 11-beta HSD2 enzyme, which metabolize cortisol to aldosterone. Obesity is an important contributor to all components of the substrate remodeling, not only because of the electrical remodeling, but also because of the contribution to left atrium enlargement and fibrosis, and also by increased oxidative stress and inflammation, increasing the chance for reentry and ectopic activity, and together for atrial fibrillation. Especially diabetic patients has an increased susceptibility for atrial fibrillation because diabetes interfere with electrical remodeling, as you can see here, the effects of action potential duration, but also of the conduction. And not in the last, because the effect on the substrate remodeling, structural substrate remodeling. Interesting. There is a G-curve, a U-curve, between exercise and the risk of atrial fibrillation. A normal, regular endurance exercise with a more homogeneous laminar shear stress is characterized at the cell level by antioxidant capacity and anti-inflammatory properties. On the contrary, the very intense and extreme exercise, because of the non-uniform shear stress, is characterized at the cell level by a pro-inflammatory, pro-fibrotic, pro-oxidative effect, and by this pro-fibrillatory effect. There are different mechanisms involved in reversible physiological atrial enlargement. This enlargement, which you can see during regular exercise or normal pregnancy, is characterized by a positive oxidative stress and preserved atrial or even enhanced atrial function, difference from the pathological atrial enlargement characterized by increased degree of fibrosis, by increased degree of oxidation, and by increased degree of electrical remodeling, and this is usually irreversible. Took all together, the consideration of all mentioned these factors could explain the positive result in the RACE-3 study, which compared conventional therapy with risk factor-driven upstream therapy, including mineral receptor antagonists, statins, renin-angiotensin system inhibitors, and cardiac rehabilitation by physical activity, dietary restriction, and counseling. All this acting on the upstream therapy of the atrial fibrillation. And you can see in this study, the upstream therapy demonstrated superiority in maintaining sinus rhythm at 1 year compared with conventional therapy in patients with risk for atrial fibrillation, patients with early persistent atrial fibrillation and heart failure. Therefore, upstream therapy works. The story does not end here. There are so multiple ways at the crossroad of atrial remodeling, which imply a variety, multiple targets for upstream therapy. Moreover, the concept goes even deeper at the intimate level of the myocyte or the myofibroblast, when structural remodeling, electrical remodeling, and the profibrillatory properties could be influenced by the calcium metabolism of the metabolic remodeling of the cardiac myocytes. So, dear friends, remembering what Shakespeare said once, there are more things in heaven and in earth, Horatio, that are dreamt in your philosophy. I thank you for your attention.
Thank you very much, George, for this fantastic overview of the complexity of the pathophysiology of atrial fibrillation. It's now, for me, a privilege to introduce Professor Jordi Heijman from the University of Maastricht, who's going to talk about new alternatives, new antiarrhythmic drugs and anti-inflammatory drugs for treatment of atrial fibrillation. Please, Jordi.
I would like to thank the organizers for inviting me to talk to you today about the antiarrhythmic drug Gladiator War, the new competence. My name is Jordi Heijman, and I work at Maastricht University in the Netherlands. I do not have any relevant disclosures for this presentation. As you know, atrial fibrillation is an important clinical problem. It is highly prevalent, associated with adverse outcomes, and also its treatment is very costly. Effective rhythm control is an important component of atrial fibrillation management, as it will improve quality of life and may even improve outcome in some patients. For example, in the bottom right, you see the recent EAST study that showed that early aggressive rhythm control strategies reduce or improve outcome compared to usual care. What I hope to do today is to convince you that better antiarrhythmic drugs are needed to improve atrial fibrillation management. Indeed, traditionally, or at least the last 2 decades or so, a lot of attention has been paid to ablation of atrial fibrillation. You can see that here, based on PubMed publications, in gray are ablations, very pronounced increase, which was not the case for publications on antiarrhythmic drugs. Nonetheless, antiarrhythmic drugs are really important. For instance, this recent summary by Markman and colleagues shows that the rate of antiarrhythmic drug prescription nearly tripled between 2004 and 2016. And given the number of patients with atrial fibrillation, there will always be a large group that will be treated with antiarrhythmic drugs, possibly in combination with ablation. Nonetheless, there are, of course, important limitations for currently available antiarrhythmic drugs. Yes, they all show antiarrhythmic properties. You can see that they are to the left of the line equals 1, but they're certainly not perfect. The typical efficacy of antiarrhythmic drugs is between 30 and 60%. Perhaps even more importantly, almost all of the antiarrhythmic drugs that we use to date are associated with significant proarrhythmic risk. And as such, the choice of antiarrhythmic drugs is primarily determined by safety considerations. Now, this can in part be explained by the complexity of current antiarrhythmic drug therapy. All of the drugs that we use target multiple molecular mechanisms. Just give you one example here, dronedarone really has effects of all 4 von Willebrand antiarrhythmic drug classes. It targets sodium channels, potassium channels, calcium channels, as well as alpha and beta receptors. Similar things hold true for other antiarrhythmic drugs. And we take these drugs with these numerous targets and we give them to very heterogeneous patients with different AF mechanisms and expect that it works in all of them, which of course it doesn't. So how can we go from here? Well, there's 2 important components that are being pursued. One is to improve safety by targeting atrial-specific ion channels, and one could be to improve efficacy by really targeting nodal points in atrial fibrillation pathophysiology. I'll give you some examples of both. First, improved safety. There are important electrophysiological differences between the atrium and the ventricle. And indeed, there are several repolarizing potassium channels that are predominantly expressed in the atria. This would enable atrial selective antiarrhythmic drug therapy. There are 2 prime examples that have been looked at in the past, the ultra-rapid delayed rectifier potassium current, or IKUR, as well as the acetylcholine activated potassium current, IKACH. And although these have shown promise in preclinical studies, the initial clinical results have been disappointing, and to the best of my knowledge, these targets are no longer pursued. However, there are others. 2 promising targets that are still actively investigated are the small conductance calcium activated potassium channels, or SK channels, as well as 2 pore domain potassium channels, particularly this TASC1 variant. And given the time, I only have time for one example. I'll show you some of our data on TASC1. So a lot of this work was done by the team in Heidelberg, Constanze Schmidt and Dirk Thomas, but in a collaboration, we could show that 2 pore domain potassium currents, which were traditionally considered a large family of so-called background potassium currents, that there is one member, this K2P3.1 or TASC1, which is atrial predominant and upregulated in AF patients. You can see that here at the Western blot level, increased levels in patients with atrial fibrillation, very low expression in ventricular samples showing this atrial predominant nature. Also at the current level, you see this pronounced increase in patients with atrial fibrillation. Therefore, inhibition of this channel would be expected to result in atrial predominance prolongation of repolarization. And indeed, you can see that here experimentally in action potentials recorded where inhibition of task 1 prolongs action potential duration, particularly in samples from AF patients, as well as in the computer model that we built. You can quantify this as well, and you see similar results. That was in 2015, but already soon thereafter, in another collaboration published in 2017, we could show that the picture is a little bit more complex. Because yes, atrial fibrillation upregulates this channel, but there's a pronounced decrease with reduced left ventricular function. You can see that here, if you compare, you see the increase with AF, but if you compare blue and black, that for every corresponding rhythm status, there is a reduction with a strong reduction in left ventricular ejection fraction. If you ignore rhythm status and just plot it as a function of left ventricular function, you get this progressive decrease in current. So we hypothesized that downregulation of task 1 channels in patients with reduced ejection fraction might impair the antiarrhythmic effect of task 1 blockade. To investigate this, we used computational modeling. We developed 4 populations of models, one reflecting sinus rhythm with a normal LV function, AF with a normal AV function, sinus rhythm with a reduced LV function, and AF with a reduced LV function. And with these models, we did 2-dimensional tissue simulations in which you can initiate re-entry. See an example here, AF tissue. And we could show that we could not initiate this re-entry if we blocked the task 1 channel. You can see that here in the screenshots. So that was in conditions representing AF with a normal LV function. If we did the same with a reduced LV function, you can see that the effect of blocking task 1 channels is much smaller, suggesting that you would really need to target this treatment to specific patient populations. Now, these are acute effects in models. What about the long-term effects? These have recently been investigated by the group of Constanze Schmidt in an interesting pig model, in which over 14 days the substrate for atrial fibrillation by burst pacing is created, and they compared regular pigs with the ones treated with this task 1 inhibitor A293. They could show that this A293 prolonged atrial repolarization duration or refractory period without changing the ventricular refractory period, and had a dramatic impact on AF burden. So, can we target task 1 in patients? We think so. Recent data from our collaboration that was published a few weeks ago shows that the already FDA and EMA approved respiratory stimulant doxapram is actually a potent task 1 inhibitor, and that doxapram prolongs atrial repolarization duration in pigs and human atrial samples and reduces AF burden in pigs and computer simulations. So that creates some opportunities using task 1 as an doxapram as a task 1 inhibitor and an antiarrhythmic drug. And indeed, the group in Heidelberg is currently conducting the DOCTAS trial, doxapram conversion to sinus rhythm study, in which they are looking at the antiarrhythmic effects of doxapram. And we're eagerly awaiting these results. Then about targeting nodal points in AF pathophysiology. Calcium handling abnormalities play a central role in AF pathophysiology. And there is emerging evidence that inflammation and inflammatory signaling may be a key AF promoting mechanism. Some of this comes, for instance, from postoperative AF, which affects about 30% of patients undergoing cardiac surgery. You can see some of the data from our recent Surgress paper here, where you can see the incidence of postoperative atrial fibrillation in the bars, and this parallels the increase in inflammatory markers, in this case CRP, following surgery. And indeed, if we take atrial cardiomyocytes from these patients at the beginning of surgery, and we subject these cardiomyocytes to an inflammatory stimulus, interleukin-1, then particularly those samples of patients that go on to develop postoperative atrial fibrillation show more of these calcium handling abnormalities indicated with arrows, suggesting that modulation of inflammatory signaling may have important antiarrhythmic properties. Indeed, data from mice, this was work done by Nadi in Houston, shows that constitutive activation of the so-called NLRP3 inflammasome, this is a multi-protein complex consisting of NLRP3, ASC, and procaspase-1 that is involved in inflammatory signaling. If you activate this just in cardiomyocytes, not in immune-competent cells, then you already predispose these mice to atrial arrhythmia. They have more premature atrial contractions, as well as a higher incidence of inducible atrial fibrillation. Moreover, also in patients, Atrial samples from patients with paroxysmal or long-standing persistent chronic AF show activation of the NLRP3 inflammasome. And we could show that also those patients that go on to develop postoperative atrial fibrillation have increased levels of NLRP3 as well as procas-base-1. Moreover, work from the group of Dobrev and Essen together with Nali could show that also patients with risk factors for AF, here diabetes and obesity, also have increased activation of the NLRP3 inflammasome. So this NLRP3 inflammasome is activated in patients with known AF, patients that go on to develop postoperative AF, as well as patients with AF risk factors, making it an interesting potential target. However, the molecular basis of this inflammasome activation is distinct, suggesting again that you may need to target a specific patient group. So to conclude, I think that antiarrhythmic drugs will remain critical for AF management. I hope that I could convince you that inhibiting atrial predominant targets such as TASC1 or SK channels may lead to safer antiarrhythmic drugs, that NLRP3 inflammasome activation is a key nodal point in AF pathophysiology and a potential therapeutic target, but that given the heterogeneous AF pathophysiology, tailored therapy will likely be essential. With that, I would like to thank you for your attention, and I look forward to the discussion.
We can hear you, Grace. Please, you are muted.
I'm sorry. Okay, thank you very much, Prof. Heijman. Thanks for sharing with us what are the new drugs on the horizon. We move on to our third speaker, who is Associate Professor Tatjana Potpara. Prof. Potpara is from the Clinical Center of Serbia, and she will share her talk live today, entitled No One Fits All, the Personalized AF Management as Simple as ABC.
Thank you, dear colleagues, chairs, greetings from Belgrade. My task today is to discuss the personalized management of patients with atrial fibrillation, which has been made as simple as ABC. And first of all, I wish to thank the organizers for inviting me to participate in this great, excellent meeting. Now, as you may know from your daily practice, patients with atrial fibrillation may actually present all over the healthcare system and may be first seen or maybe have been seen by different specialists, non-cardiologists for a long time before they reach cardiologists. And timely holistic care of patients with atrial fibrillation has been repeatedly shown to significantly improve patient outcomes, especially if started early. So in the 2020 ESC-AF guidelines, we provided a summary of key elements of management of patients with atrial fibrillation, summarized in the algorithm CC to ABC, where each letter resembles a key element of AF management. First is to confirm the diagnosis of atrial fibrillation, then to provide in-depth characterization of the patient with AF, only to proceed with the ABC pathway of treatment. A stands for avoiding stroke, most commonly using oral anticoagulant therapy, B for better symptom control, and C for comorbidities and cardiovascular risk factor identification and management. And first, let's discuss briefly the characterization of atrial fibrillation. It's a new paradigm shift that has been proposed in the 2020 ESC-AF guidelines because the limitations of the conventional classification to paroxysmal, persistent, or permanent atrial fibrillation are being increasingly recognized. And we proposed, rather than to classify, to characterize the main domains of atrial fibrillation management and risk profile, including stroke risk, symptom severity, severity of AF burden, and substrate severity, so that such a comprehensive characterization of the main AF domains may contribute to better streamline management of AF patients at different healthcare levels may inform treatment decision-making and facilitate optimal management of patients with atrial fibrillation. Since previous sessions have discussed the principles of stroke prevention in patients with atrial fibrillation, let's discuss better symptom control in this presentation. And it is very important to keep in mind that rate control in patients with AF is always a mandatory background therapy in all AF patients, regardless of future treatment plans. It also may be first choice treatment in patients with minimal or no symptoms, or can be used after failure of rhythm control therapies. And for majority of patients, lenient rate control will effectively control symptoms. But in those with progressing heart failure or deterioration of left ventricular systolic function, a more strict rate control therapy may be needed. The choice of drugs for rate control essentially depends on the presence and type of comorbidities, and there is a choice of drugs that can be used depending on which comorbidity the patient has. So in those with reduced left ventricular ejection fraction, the armamentarium is mostly reduced to beta blockers or digoxin as a sole drug or in combination. Again, a resting heart rate of less than 110 beats per minute would suffice for most of patients with atrial fibrillation. Alternative to rate control is rhythm control, and available high-quality evidence clearly support consideration of rhythm control for symptom improvement, better symptom control, and improvement of quality of life. Of course, rhythm control therapies will work best only if a holistic management of patients has been practiced, so that all cardiovascular risk factors, all comorbidities are identified and managed properly. The decision on rate control is essentially based on the presence of symptoms. But even in patients who are apparently asymptomatic, keep in mind that there may be ongoing subconscious adaptation to the arrhythmia. So a trial of cardioversion and rhythm control seems prudent in most patients with atrial fibrillation, because some patients will come back to you after successful cardioversion and they will say, "Oh, doctor, now I realize how unwell I have been for a while." That is during the arrhythmia. And there is a list of factors suggesting that rhythm control will be successful. So a trial of rhythm control therapy has been advocated in the new guidelines in most of patients with atrial fibrillation. Should we opt for cardioversion, whether electrical or pharmacological, we need to obtain information about hemodynamic stability, current oral anticoagulant therapy status, whether the patient is already therapeutically anticoagulated or not, and how long is the duration of the current AF episode. And that is how we provide appropriate treatment option for our specific patient. What is new in 2020 AF guidelines is that, in contrast to previous recommendations that after successful cardioversion, all AF patients should receive a 4-week oral anticoagulant therapy, there is a recommendation that in patients with a short duration of atrial fibrillation, less than 24 hours, at truly low risk of stroke, with CHEST score of 0 in males or 1 in females, oral anticoagulant therapy post-successful cardioversion may be omitted, but it's an optional recommendation and should be done in agreement with patient preferences. Long-term oral anticoagulant therapy is, of course, decided not based on the presumed success of rhythm control, but based on the individual patient's stroke risk profile. And the choice of antiarrhythmic drugs for long-term rhythm control after successful cardioversion is again based essentially on the presence and type of concomitant comorbidity, cardiovascular comorbidity, and left ventricular ejection fraction. But in most patients, the efficacy of antiarrhythmic drug therapy will be at best modest. They will help in controlling symptoms, but they will rather reduce the recurrence of atrial fibrillation than completely eliminate the arrhythmia. And importantly, over the long-term course of treatment, we need to consider proarrhythmic risks and extracardiac side effects from drugs such as primarily amiodarone. So in recent years, the availability of catheter ablation of atrial fibrillation has been increasing constantly, and the indications for using catheter ablation for rhythm control have been upgraded in the 2020 ESC guidelines to include catheter ablation as a first-line treatment option in patients with symptomatic paroxysmal atrial fibrillation or even those with persistent atrial fibrillation without major risk factors for recurrent arrhythmia, as well as a first-line treatment for patients with AF and heart failure, especially those in whom a tachycardiomyopathy caused by irregular fast heart beating has been suspected. Also, there are some changes in the AF ablation recommendations after failure of antiarrhythmic drugs, and there's been upgrade for such indications, which are extended even to patients with persistent atrial fibrillation and major risk factors for AF recurrence, and this has been based on the most recent trials that have been investigated catheter ablation. It is of key importance to manage concomitant cardiovascular risk factors such as obesity, hypertension, and others, not only to improve patient outcomes, which is the most important, but also to improve the success of catheter ablation of AF and to improve long-term rhythm control therapy. And that is why cardiovascular risk factors and comorbidities management has been generally recommended for patients with atrial fibrillation as class 1 recommendation as a part of holistic integrated management of patients with AF. Recently published East AF-NET trial has suggested that early aggressive rhythm control actually improves patients' outcomes in terms of survival, primarily cardiovascular death and stroke in comparison to usual care when rhythm control is guided by patient symptomatic status. However, the interpretation of the East AF-NET trials needs some caution because there was a difference in the early rhythm control arm versus usual care. And the difference was, although in both arms, patients received oral anticoagulant therapy and risk factor management, the early rhythm control arm has been subjected to intense exchange of information with study team, which provided feedback as needed. And it was, as per the study protocol, there was twice weekly plus symptom-driven ECG patient self-recording and transmission to the study team with feedback as needed. This may have resulted in more active involvement of patients in the course of treatment with better adherence to all therapies, including oral anticoagulant therapy and upstream therapies and concomitant comorbidity therapies. And there are increasing evidence from post hoc analysis of randomized trials, from observational trials, and finally from a prospective randomized clinical trial, that such integrated holistic management of AF patients with intense interaction with patients and well-structured intense follow-up actually improves patient survival and all major cardiovascular outcomes. So we still need high quality proof that it is really early rhythm control that makes the difference. And finally, it is of essential importance that our care for patients with atrial fibrillation is patient care. So we need to inform the patient about the risks from arrhythmia, the purpose of treatment, the risks from treatment, and best option to avoid complications of treatments such as oral anticoagulant therapy and other therapies. Only such integrated holistic management in close collaboration with patient may actually improve best patient outcomes. Thank you for your attention, and I'm looking very much forward to the discussion. Thank you.
Thank you very much to all speakers for this very interesting overview. Professor Dan has stressed the complexity of atrial fibrillation with diverse and severe and complex, very complex pathophysiological pathways. Professor Heijman has opened new windows of new antiarrhythmic drugs and the role of inflation. Professor Puat has also stressed the reality, the actual reality with several limitations from antiarrhythmic drugs and also from ablation. Since we have these limitations and we are still needing antiarrhythmic drugs, we have several questions from the audience which are very interesting. The first would be for Professor Dan. Do you think we need to treat patients directly or very quickly after diagnosis of atrial fibrillation with ACE inhibitors or ARBs and with the statins? And which impact would this have in primary care?
Despite lack of very convincingly randomized controlled trials in controlling with upstream therapy, with traditional upstream therapy, because I have shown that this is new paradigm for upstream therapy, there are a lot of indirect evidences that early treatment with renin-angiotensin aldosterone system inhibitors and statins is beneficial in prevention, in primary prevention of atrial fibrillation. Therefore, shortly, for patients with other indication for such therapy, I strongly indicate the use of angiotensin converting enzyme inhibitors or anti-aldosterone receptor blockers in small dose, or statins, and even ARNI for preventing atrial fibrillation.
Thank you very much, George. Jordi, would you comment on that also? Because you also expressed that there are several pathways which are complicated, and probably a combined therapy would have a major impact in our results. Could you please comment on that? You're an expert in that field.
I think it's indeed, it's an excellent point that Professor Dan makes. And what I would like to stress there is that indeed, as he showed in his presentation, that we also know now that a lot of these upstream therapies actually also have direct electrophysiological effects. So they may, in effect, also have a direct antiarrhythmic effect. So they may do something for the long term, they may do something for the short term. In the end, I think it's really this combination of trying to modulate the substrate while simultaneously targeting the electrophysiology in such a way that we prevent new episodes. So the combination of upstream therapy, classical AADs used in the right way, and potentially new antiarrhythmic drugs, I think is the way forward.
Okay. Grace, do you wanted to raise a question?
Microphone.
Hello, I would like to raise this question to Prof. Popara. You have mentioned that the ABC pathway is the way to gather all the resources to treat AF. But do you think, from an institutional perspective, what resources will be most needed to increase adoption of the pathway? And perhaps what is the top challenge that will be faced when trying to do so many things in the pathway?
Thank you for that question, which is very important. Actually, the beauty of the ABC pathway is that it only gathers the aspects of care that are already there, but in some healthcare systems may not be yet well connected with well-defined interactions. So my view is that it is not so much about new resources. It's only that we can see different specialties and have timely access to consultation and do what we would anyway do, but knowing that such an action and such a management of patients with AF will improve their outcome. So it's not, it's mostly directed towards cardiologists and arrhythmologists. It's not just to manage the arrhythmia itself, it's to manage the whole patient with all risk factors that patient has.
Mm-hmm. Okay,
There's
so
another
mm-hmm.
please, Grace.
Go ahead, sorry. Yeah.
There's another question regarding exercise. From one side, we hear every day that exercising is very important, it's necessary. But on the other way, we have heard and we know that exercise can trigger atrial fibrillation. Can you please comment a little bit on that? How much exercise should be considered healthy? Is it a cumulative effect? Is it depending on age of the person? Could you comment a little bit on that?
Okay, of course, I can begin it very shortly. It is now somewhat known that there is a G-carb, a U-carb for the endurance exercise. So a very, very strong, very powerful exercise could precipitate atrial fibrillation, especially in older persons and with risk factors. But also it was demonstrated recently that the hard exercise could provoke atrial fibrillation in athletes, in endurance athletes, and there is an increased incidence of atrial fibrillation in such kind of athletes. Obviously, this should not reject the extremely important contribution of the exercise in preventing atrial fibrillation. It is only the extreme of the spectrum that very strong exercise could precipitate atrial fibrillation in susceptible persons.
Yes, the question perhaps is how much it is for one person, because the perception of what is too much, it's very different in between the persons. For some people, running 10 kilometers is a long way. For other 14 kilometers twice a week, it's nothing. So my feeling is that the perception has a big influence on what is too much. But I agree with you. Statistically, endurance exercise and over a long time promotes atrial fibrillation.
If I may complete, I'm sad to tell you that indeed I have no cutoff point. And after my knowledge, nobody has a cutoff point. But it is very clear that this is dependent of age and of the training state of the patient. So this should be taken into account.
We have another interesting question from Professor Heijman, who has expressed that there are some new alternatives. In which alternative would you put your money on? What would you risk in task 1 inhibition or in inflammasome? Could you name some molecules? Would you also stress a combination of approaches?
Yeah, I think that's the $1 million question, literally, right? It is very challenging, and I think at the moment, especially the development of new antiarrhythmic drugs, the regulatory hurdles are such that we will need large-scale outcome trials to assess safety, making it very difficult. So a very judicious choice is needed. I think that's one argument, a pragmatic argument, to go for the repurposing, such as with the doxabrand drugs that are already approved and use those. At the same time, I do think we do need new compounds as well. So we should, for the longer term, try and develop that. Then I think for safety, really the atrial selective drugs are very intriguing, are very promising. Though we should not, at the same time, not just say, well, atrial selective, no effect on ventricular. means safe, because we know for doxapram it may affect an effect on pulmonary hypertension. The SK channel inhibitors may have effect in the brain. So there's more to safety than ventricular proarrhythmia. So that's another layer of complexity.
Thank you very much for your comment, and I agree with you. Also, the interactions with other drugs have to be very, very carefully evaluated. For example, interactions with anticoagulants, which in this regarding, we know that the NOACs, which are excellent drugs, may have interactions with some specific antiarrhythmic drugs, and every physician must know on that if you want to treat correctly the patients.
Agreed, yes.
Tatiana, you wanted to make a comment, I think?
Yeah, I wanted to ask Jordi, in comparison to oral anticoagulants, which have well-defined point of action, they inhibit the process, which is very harmful for patients with AF. Given the complexity of the development of AF, can we ever expect to find the sweet spots to have a single drug that will successfully, with such great success, suppress the occurrence or the recurrence of atrial fibrillation, or it will be selected drugs for selected subsets of AF patients?
Yeah, I think the latter is certainly the way to go. I don't think we'll get the magic bullet. The pathophysiology is too complex for that. But the point you raise is very valid, because of course that again makes the development much more difficult, because doing then a large-scale trial to assess safety in a subset of patients, well, it just gets practically complicated. But it's what we probably will have to do in some way.
Thank you very much for the question, Tatiana. In this regard, there's a question from the audience for you. There's one person asking if you want to have rhythm control in a patient with early detection of atrial fibrillation, which is your preferred drug?
That's a great question, and that's in clinical practice is highly relevant. And the shortest answer would be we need to personalize. Though I'm afraid that by frequently using the term personalized, we leave clinicians without any instructions what they should do in their office or at bedside. So to extend a little bit, it will depend strongly on the individual patient risk profile, the severity of arrhythmia substrate, and patient's age and comorbidities that may limit the use of specific antiarrhythmic drugs. So in a very young patient in whom, for example, first the incident AF has been provoked by intense physical activity or drinking, simple avoidance of the risk factor may do well without any treatment, without any antiarrhythmics. In those with preserved left ventricular ejection fraction and other significant comorbidity, if they have a moderate substrate, arrhythmia substrate already developed, probably class 1C will do. Whilst in those with reduced left ventricular ejection fraction, of course, we still have amiodarone only. Speaking about vernaculant, which is for cardioversion of atrial fibrillation, and dronedarone, these drugs are not widely available in all parts of the world, so they can be used in the countries where they are approved and available.
Regarding so oral drugs?
Back to patients' individual risk profile.
Yeah. And regarding antiarrhythmic oral drugs, would you prefer propafenone or would you prefer flecainide as first choice if the patient has no structural heart disease?
My personal preference, which goes in parallel with the increasing risk of recurrent AF, would be flecainide over propafenone. In those who are at relatively low risk of recurrence, I would opt for propafenone.
Okay. Professor Heijman, you wanted to make a comment, I think?
Yeah, I just wanted to stress that the point that Professor Papara makes is essential, that the first step, rather than developing new antiarrhythmic drugs, is really using the ones that we have in the proper way. And I mean, I think Professor Dan is the expert in that, but it is becoming a little bit of a lost art as well to really use those in the most optimal way. So I think education of both of patients, but also of other cardiologists in the use of antiarrhythmic drugs is an important step besides the development of new things.
Thank you very much for the comment. It's really meaningful. And regarding that, just very short answer, please, because we are running out of time, but which is the actual role of calcium channel blockers? Because several years ago, they were very often used, but we hear very few today regarding of them. Calcium channel blockers, which would be the role today in atrial fibrillation?
As rate control. At this moment, I don't see for the traditional calcium channel blockers, of course, the phenylalkylamine class and the benzodiazepine class, I don't see any other role than preserving of the heart rate.
But I think that you were alluding on some sort of enthusiasm that has been raised years ago about potential role of these drugs in attenuating arrhythmia substrate and slowing down the development of the substrate for AF persistence or occurrence. But I'm afraid that
nothing proven.
Yeah.
Exactly, but because they are cheap, usually cheap drugs may be used in some countries. Therefore, I wanted to ask this question. Well, I think we are running out of time. We would like to thank every one of you. It has been really a privilege and a pleasure to hear the three speakers and to share this session with Professor Chang. Thank you very much, and we wish you have a pleasant day. See you again so soon as possible. Bye-bye.
Thank you so much. Bye-bye.
Bye-bye. Thank you, Prof. Antoni. Thank you, everybody, for